But I am going to be talking about evidence-based approaches to the assessment and evaluation of child mental health. And just to give you a little bit more background specifically around that, I've been pretty much involved in clinical assessments for most of my career as a psychologist. Starting in graduate school, I was a member of an assessment service that was run by the clinic at the University of Georgia, and then through both of my faculty positions at the University of Alabama and then at the University of New Orleans. So for 22 years after that, was a director of an assessment service. While at Alabama, I did a private practice where one of the main things we did were evaluation. So I've been involved in the clinical aspects of it for well over 2 decades. But I've also been involved in it in many other ways, including as an instructor. I've taught assessment for the last 22 years to doctoral students. And that's where this textbook came in. And that's my disclosure for the talk, for the conflict of interest. I do receive royalties for this textbook. But this textbook came out of my sort of lack of satisfaction with what was available for training people on evidence-based approaches to assessment. And so Randy Kamphaus and I did the first edition back in 1996 to try and come up with an approach to training people on how to think about assessments and do assessments that were evidence-based. I've also developed several scales related to assessments, and then have been involved in sort of trying to promote evidence-based assessments for a while. Back in 1999, I was chair of a task force for Division 12, and the exact name of it was Enhancing the Technology of Diagnosis and Assessment in Child Mental Health Disorders. And as Bill mentioned, most recently I've been part of the DSM-V, coming up with new criteria or improved criteria for child assessment. So you can see I've been at this for a while, and this sort of led me to the structure of this presentation. In the hour, I'm going to try to accomplish 3 things. I'm going to try and define what is meant by an evidence-based approach to mental health assessment, and talk about what measures can support an evidence-based approach to assessment in child mental health. And this is important because there are some people who have come up with definitions, but it's often hard with these broad definitions to say, how does that translate into selecting specific tests? Or alternative, people will evaluate tests and say, this test is part of an evidence-based approach and this test isn't, without really seeing what is the overarching way that people are evaluating that. And so what I'm going to try and do is try and combine both of those. And most importantly, what I think is often missing is, what does this mean to you when you're actually doing assessments? How does this approach to assessment, this approach to selecting tests, how does this affect what you actually do with children and adolescents when you're testing them? And so that's going to be my goal for this hour, is to go through these 3 things. The thing that I want to do first, though, is you guys have probably been very well aware and have heard a lot about this movement toward evidence-based treatment. But the movement toward evidence-based assessment has been going on for almost as long, but it just doesn't seem to engender the same energy as the movement toward evidence-based treatment. And I sort of want to make the case, I think people often think that evidence-based assessment is irrelevant to evidence-based treatment, and I want to make the case for just the opposite. If you look at evidence-based treatment, the cardinal tenet of that is, when you're treating, say, a child with depression, you want to use the treatments that have been proven by research to be effective for treating depression. But that sort of rests on the assumption that you're treating the right thing. And evidence-based assessment is the way that you go about doing that. Also, if you're going to apply the research that's been done on the treatment of depression to a child you're seeing who may be depressed, you want to make sure that you're using about the same types of assessments so that you're actually applying the right research, that the research will be being done on the same types of children that you're seeing. And then finally, how do you know if your treatment is effective unless you do an evidence-based assessment throughout the course of treatment to see, is this child improving? So for these 3 reasons, I think evidence-based assessments are integral to evidence-based treatments. So what I want to start with is evidence-based approach to assessments. And I don't know how many of you guys have ever read some of the fights about how do you define evidence-based treatment and what's the most appropriate definition. And it really does get somewhat hostile at times. Unfortunately, there's not the same hostility for evidence-based approaches to assessment because there are very few attempts to really define it. One that was done, there was a special issue of Journal of Clinical Child and Adolescent Psychology done in 2005. Eric Mash and John Hunsley were the guest editors, and it was under Wendy Silverman's term as editor of the journal. And this is the definition that they gave. Assessment strategies should be based on what is known about a disorder's symptoms, etiologies, and comorbid conditions, the individual, interpersonal, and societal resources and contexts that impinge on the treatment of the disorder. Now that's a pretty broad definition. And so what we try to do is, we were asked to do a chapter for the American Psychological Association's Handbook on Testing and Assessment. And what we try to do is take that broad definition of an evidence-based approach to assessment and come up with what we felt like were 3 principles that underlie this approach. The first follows very directly from Mash and Hunsley's definition. This first principle says that everything you do when you're assessing a child should be guided by the most current and best available research. This means when you decide what should be assessed. If you have a child, let's say, that's referred because of suicidal thoughts or suicidal behavior, your first question here is, what do we know from research? What are the many different things that can lead a child to have these kind of suicidal thoughts and behaviors? And that's what should be assessed. What tests have proven to be valid for assessing those things, those constructs that are related to suicidal behavior? Once you get all your tests and you get all these scores, how should the test scores be integrated to making clinical decisions? Again, there's a body of research talking about how you do weigh multiple informants, multiple sources of information. And very importantly, once that's done, let's say you do make a diagnosis of depression. What does research suggest in terms of the most appropriate treatment? I don't know how many of you guys have ever read a report. I read one, last year from a practitioner that did the assessment and that said, referred a child for mental health treatment and said, the mental health treater should use these results to determine the best course of treatment. No recommendations about how their results would lead to treatment. So what recommendations should be based on what is the best available research? So this is the first principle. And again, you can see that follows very closely to the definition that Mash and Hunsley gave you. But here's the second principle. Results from tests should only be used for making interpretations for which they've been validated. One of the most controversial parts about evidence-based assessment is when people start going into, this test is evidence-based, this test isn't. There's an inherent problem with stating that for any test. The inherent problem is tests themselves are not reliable and valid. Scores and interpretation from tests are reliable or valid. Let me give you an example. Specific scores from tests can be reliable under certain conditions and with specific populations. Let me give you an example of, I know I'm sticking with depression for a little bit here, but the Child Depression Inventory has proven to give you reliable scores related to childhood depression, but not for 4- and 5-year-old children. So they give you reliable scores for certain age groups, not for every child. So you can't say that the Child Depression Inventory is reliable. How many times have you heard a person say, this test is valid or this test is invalid? You can't say that. Certain interpretations from tests can be valid and others can be invalid. And so it depends on, is it valid for the interpretations you want to use? Let me give you an example. Many of you guys probably are familiar with the Child Behavior Checklist, right? One of the more commonly used assessments, gives you very reliable norm reference scores. And there's a scale on this called the Aggressive Behavior Scale. But if you look at the content of this scale, it actually has broad conduct problems. It has things like argues with adults, defies adults. Very few are specific to aggressive behavior. So a valid interpretation of this scale would be if you want a norm reference about how severe the child's conduct problems are. An invalid interpretation of the test would be a child with high score is physically aggressive. And I can't tell you how many evaluations I've heard where a child who scores high on this aggressive behavior rating scale, the person then interprets this child is very aggressive, when in fact, this child may not be aggressive at all. And so this is an example of you can't say the aggressive behavior ratings, the scale of the CBCL is valid or invalid. It's valid for certain interpretations. And again, I think this is a thing that's part of the evidence-based treatment, is realizing what interpretations do you want to make from this test, and have they been validated? Then here's the third principle. Those first two, I think, are a part of most definitions of an evidence-based approach. This is something that I will admit grew out of my training of students. When we have students that are learning to do assessments, we started this exercise where we treated the assessment of a child just like almost a N of 1 research study, where it was guided by hypotheses and hypotheses testing. And what I found is over the years, even in my private practice, it was incredibly helpful to go through this exercise to really think about the evaluation. And here's what I mean by a hypothesis testing approach. Every step of the evaluation is guided by hypothesis testing. So for example, from the referral question, like why is a child doing poorly in school? You develop hypotheses. What are all the reasons that could lead a child, based on research, to have problems in school? Now, one of the difficult things about this is assessment situations can vary a lot. So sometimes you have people will do just very cursory intakes, and then we'll do a follow-up interview to get more information before they design their tests. So your initial hypotheses may be based on more or less information, but the starting point is to say, sit down and say, okay, what are all the possible reasons why, based on research, a child could be doing poorly in school? And you can probably think of a large number, not just the two I have here. A learning disability. A child has problems sustaining attention. But this is important. Then what you think is, all right, what data would support one hypothesis over another? What data, what results would make me think, all right, this seems more like a learning disability versus this seems more like a child that has attentional problems? Or this child is having problems that seem to be more related to stressors at home. And you see, you can go on and on from this, but the whole key is, all right, what data? And you see how this is a lot of how we do research. We have our hypotheses, we go into, we say what hypotheses would support our theories, and then we design our data collection. What measures would help us collect those data that will be used to test our hypotheses? And we collect the data. Now, for those of you guys who do research, what theory or hypotheses does this seem to come closest to supporting? And it's the same thing with an evaluation. When you look at all the data, which hypotheses does this seem most consistent when you're interpreting the assessment? And so it provides you a structure for how to think about a case. And from each step of the case, you're looking at it as what are some hypotheses about what's going on, and what data would make me support one hypothesis or another. So those are my 3 principles in terms of an evidence-based approach. And again, what I'm going to do for the rest of the talk is really say, all right, how should that guide then selecting of measures? And I will try to give you some examples of how do you apply this to individual cases. But I do think it's helpful to also think about how does this approach differ from other approaches. I'll tell you, one of the most common approaches to assessment is what I often call an intuition approach, where the person doing the assessment doesn't want to collect a lot of tests because these tests don't really capture the complexity of an individual. These scores don't really capture how complex an individual child is and all the things that are going on. And more importantly, it takes away my ability to use my wealth of clinical experience in interpreting what's going on with the child. After doing this for 22 years, you start getting these intuitions when a child comes in. And they're saying, oh man, this child is referred, that looks really like attention deficit disorder. I don't need tests to help me with that. And so I think a lot of people will go into a more intuition-based approach. That is, they don't want to be beholden by test scores for that. You also have the opposite, where people are only driven by tests. Oftentimes they will have their favorite tests or few tests that they'll use for everybody. They'll make everybody, they'll come in and they'll have their 3 or 4 tests that they'll give to every child or adolescent that comes through there, and they'll make it work for whatever the referral problem is. Rather than saying, okay, given this referral problem, what is the best group of tests that we should give? That's the test-driven approach. Also contrast this with a diagnosis-driven approach. Probably many of you guys have worked in medical settings. And, how many of you guys have been through a medical rounds where a doctor's doing rounds with a patient? And if you look at the typical rounds, they'll go to a patient and say, this child, this is a 13-year-old girl with type 1 diabetes. And then they'll move on. And that's all you need to know about that child, for their medical treatment. It doesn't work that way with psychology. To say this person has generalized anxiety disorder, you want to know a lot more. How long has this been going on? Were there certain stressors that led to the child developing generalized anxiety disorder? How do the parents react to the child when they act anxiously? And so in psychology, we may want to make diagnoses, but that should not be the outcome. And the other thing that this contrasts with, a lot of traditional approaches to assessing mental health either rely on solely assessing the child or solely assessing the child's context without anything in between. And I want to give you an example of this. In the late 90s, I was involved in an evaluation of the Department of Youth Services in Alabama. These were kids who had been adjudicated, and they had set up a court-mandated, a statewide assessment system. And what the psychologists did was they did an IQ test, the brief personality inventory, and the Rorschach. And that's what they did for every child who was in the state, and that was mandated by state law. Then the social workers did what was called a family and social history, where they got a lot of background about the child and the family and how they were, the history that, how many caretakers the child had, what kind of stressors had been going on in the family, how involved the parents were with the child, and a lot about the child's background and developmental history. But guess what? Those two things never informed each other. The social workers who were doing the social history said, look, these scores that the psychologist gave me never gave me anything that helped this child's treatment. So they never used any testing to help them make their treatment. On the other hand, the psychologists doing these psychological tests never had any information about the child's context in which to interpret the information about the child's personality. And to me, this anchors both of these approaches to testing. My view is an evidence-based approach to testing means you integrate those two. And that's what I'm going to outline for you here. In doing so, what measures can support an evidence-based approach to treatment? And this was very difficult to think about because think about the hundreds of psychological tests. There was no way in an hour I could go through and say, here are some, the tests that are validated, here are some tests that are not validated for certain decisions. But I do want to cover first some general issues and then go through certain types of tests and what they tend to be good for in evaluations of kids' mental health. Let me start with some general issues. The first issue is one of the difficulties in defining principles for evidence-based approaches to treatment is how diverse the goals of treatments can be, the purposes for doing evaluations. What I'm going to talk about most of the time here are what's called diagnostic and treatment referral assessments, where you do a complete assessment, come up with what you think is causing the child's problems, and then the child is referred to treatment. But also an important part of assessment is treatment monitoring that you do during the course of treatment to see, is this treatment being effective? And this will determine what tests you use. So for example, you can have something that is very good for diagnostic purposes, but is not sensitive to change. Maybe because it's as simple as the questionnaire is, ask the parent to rate the child's behavior over the past 6 months. Yet you want to give it at 1 month of treatment, 2 months of treatment, and 3 months. People, that's not going to change. And so it may be very good for giving an overview of how the child's been over the past 6 months, but may not be sensitive to treatment. The other thing is sometimes your tests are determined by specific requirements. Sometimes school systems require specific tests for determining a child's eligibility to schools. I'll give you one example. We referred a child, the mother came in and said this child was being hospitalized in a residential treatment center, and they wanted us to do the Milan inventory. Well, we said, the Milan's not, has some uses, but that's probably not the best thing to determine if the child should be put into this residential treatment and what the treatment should be. So we gave this really great state-of-the-art assessment, put the child through about 4 to 6 hours of assessments, and came up with, what we thought was going on and what we thought the residential treatment center should do. And we give this they go over the report with the mother. The mother brings it to the residential treatment center. We get an irate call from the mother, and they said they want the Milan. And we said, but we're not sure that's the best thing for the child. They said, well, so we called the residential treatment center after we've done all this, and they said, all we do is we put kids into groups based on their personality profile in the Milan, and we won't accept them unless he has it. Again, there was a specific requirement by this place. And what we should have done is checked on that beforehand, and we would have given the Milan as part of our full evaluation of this child. So again, sir, you have to understand if there's specific requirements of the testing situation. A big one is the developmental level of the child and how this affects your selection of tests. So for example, we're going to talk a little bit about structured interviews, but structured interviews in terms of where you sit down with structured questions for a child really have not proven that good for kids under 9. We were part of a validation of one of the early structured interviews, the Kitty SADs, and we were giving it for kids as young as age 6. And that was the most god-awful experience of my career, trying to interview a 6-year-old. But again, the types of measures will depend on the child, the age of the child, and even the method of administration. Frequently, when people are assessing a young child, they'll want to bring the child in and play for a little bit, because that gets the child comfortable with the testing situation, get them comfortable with the examiner for a young child. But if you look at the research, for very young children, it's very hard for a child to go from an unstructured setting to then all of a sudden go to a structured setting. And to be honest with you, most kids are very nervous about the situation. They know something's coming, and that play period is just more anxiety producing. They want to get to, all right, I want to know what's going on. And when you get to more structured questions, there are more demands that the child, oh, I know what they want. They just want me to answer these questions. They want me to put these blocks together into a block design. They want me to just answer these questions about my feelings and behavior. And so we often find, even for young kids, starting with structured tasks that have good demand characteristics. And again, after you explain to the child, you let the child ask questions, you make it clear why they're there. And even when you're talking about what informants, whether you get information from the child, from the parent, or from the teacher, or all of the above, research has shown that that depends on the age and developmental level of the child. One of the things they've shown is that teacher report for most things tends to decrease in importance as the child gets into junior high and high school, where teachers have the child for less time during the day. Whereas child self-report actually becomes more important as the child ages, and parent seems to be sort of good throughout. And again, there's some variations depending on the types of problems you're talking about, but there are variations that depend on the child's developmental level. One of the things that we've also found from research is that there is no perfect assessment for anything, and that the optimal way of assessing any construct is by having multiple measures of that construct. Related to that is recognizing that, it is very rare if a child is having problems that they're having problems in one area. that it's just anxiety, or just oppositional behavior, or just conduct problems. They frequently have multiple problems in adjustment. And you have to know that because it means that besides assessing what you think might be the primary problem, you need to screen for a lot of other problems, leading to a pretty comprehensive assessment. The last thing is assessing the child's context. As I mentioned before, in psychology in particular, testing has often been viewed as solely attesting the child and individual differences in the child. And again, I think an evidence-based approach to assessment says you can't understand the child's personality, their behavior, without understanding his or her context. So, what are types of assessments that can be part of this evidence-based approach to treatment? And what I'm going to do, and again, I know this is going to be pretty streamlined, I'm going to talk about three types of assessments that should be part of any evidence-based approach to treatment. And then I'm going to talk about some that could be used, and then some that that have a pretty limited usefulness. And I'm going to start with behavior rating scales. Any evidence-based approach to treatment should include behavior rating scales. And these include self-report from the child as well as report from others. Why is this? One thing is they're time efficient, they're reliable, and one of the things that is very important for an assessment, they typically are normed reference. What I mean by that, it's one of the best ways to say, is this child's attentional problems more than what you'd expect from other 9-year-olds? Is this adolescent's social anxiety more than what is typical in adolescents? This is typically done best by behavior rating scales. Often behavior rating scales have what's called validity scales. You probably are familiar with this, where it can detect response styles for the child, whether they're inconsistent in their responding, whether they're trying to look good, have a socially desirable or a view of trying to make themselves look good, or fake bad, making themselves look bad. What's also very helpful is you have some what are called omnibus rating scales that can help you screen a lot of areas in a very time-efficient manner. So let's say you are assessing a child for attention deficit disorder, but you also are concerned that he's showing a lot of anxiety. What the rating scale can give you is at least some screening of the level of anxiety, while you get more in-depth information about the child's attentional problems. There are also specific rating scales that are specific to anxiety, to depression, to conduct problems, that should that be your focus of evaluation, you can get more in-depth assessment. Now, with that said, and I've hopefully done a decent sales job on behavior rating scales, they're not perfect. They are subject to the bias of the respondent. People can try to portray a certain response set on these rating scales, and it often misses important parameters. So you know the child is having a significant level of depression. What are some other things that are important to know about that? When did it start? How long has that been going on? Is it confined to sort of discrete periods? Does the child go through periods of depression and then come out of it and is fine for a while and then go through other, and they've gone through multiple episodes? Often, rating scales don't give you those important parameters, and it doesn't allow you to have the parent elaborate a lot. So this child is being aggressive. When did that start? What do you do about it? When a child acts aggressively, how do you respond? Those things often can't be determined by a rating scale, which leads to the second part of any evidence-based approach to treatment. These are unstructured interviews. We use unstructured interviews a lot to clarify the referral question. So just that referral question I gave you a little while ago, the child's having problems in school. Think about all those questions you would want to know about this. How long has that been going on? Is that just this school year? Has it been consistent throughout his school, time he's in school? Has the school tried different things to help them? What types of problems is he having? Is it on tests? Is it just on test day? Does he have problems in other areas? Is it just in homework or in seat work? Is it just in math or is it across the board? All those questions are important for clarifying, what types of problems is this child having? It also helps with the functional analysis of behavior. The example I just gave you with aggression. It does help you say, okay, how does the parent respond when the child is aggressive? Do they get into an argument, it escalates to where everybody's yelling at each other and then everybody just goes off into their own room? Does it escalate to the point where the child starts becoming, does it start kind of low level with just angry words and then often escalates into physical altercations? It helps you to look at, what are the contingencies operating? And it often, the unstructured interviews allows you to get a lot of client-specific information. I don't know how many of you guys have had the joy of testifying in court in a custody evaluation. And you may give a lot of information about a child. And I remember one in particular where, we were talking about, the child's level of anxiety. But the lawyer specifically asked me, is she anxious about when she visits her father? That doesn't come from a rating scale. You've got to get some client-specific information by talking to the parents, by talking to the child, by getting a lot of information that may be specific to that case. It allows for that information that I mentioned that you can't get from rating scales, and often allows you to get information from which there's no structured way of getting the information. So let's say you really want to know sort of the emotional climate in the family. And there are some rating scales. The family assessment device, there are other types of family measures, but you want to get a certain aspect that you can't find a good measure. Do you just not assess it? No. That's what you get through the unstructured interview. Now, you have to recognize that this information is subject to the bias of the interview. It's often hard to estimate how reliable that information is, and it does require a lot of training. This is the thing that is the hardest when you're training new students. They're real comfortable sitting in there handing out measures to the child and scoring those measures, but getting them ready for that unstructured interview. That requires a lot of supervision, practice, work, and experience. But here's what I want to paint to you with just these two first measures. You can see a lot of times people would say this unstructured interview, you don't have any evidence for the reliability and validity of what you're doing. This is not part of an evidence-based assessment. My view is that's not true. If you just use the unstructured interview without the behavior rating scales, it would not be evidence-based approach. But I will also say the opposite is true. If you just hand out rating scales without getting a lot of background information, a lot of context that research said is important for understanding, you're also not doing an evidence-based approach to assessment. And then the third one, behavioral observations. This is where you actually observe the child and you get information about the child's behavior that's not filtered through any informant. It places the behavior in context. We just recently had a child who was acting up in class. The teacher described him as, he's acting like, I don't know if you've ever heard this before, the class clown. And so we went in and did an observation in the classroom. And this child, it was pretty clear, every time, he'd start doing things and people would ignore him, and then he'd start getting up, when we were there, he actually got up on his desk and started singing some rap song, which I don't remember exactly, don't know exactly which one it was, but everybody thought it was hilarious. He got, the whole class broke out laughing, they cheered him on. He got sent to the office and got a detention. Why did he do that? The class loved it. That was the only time he got attention. That puts the behavior into a pretty clear context here that you wouldn't get just from knowing that this child is a class clown from the teacher's report. Also observing children during testing. We do testing, in pretty long periods. We actually do most of our testing all day on a Friday. And it's pretty important to see how the child is doing toward the end of testing, at 3 o'clock in the afternoon, doing rating scales. and whether the child is making really nice patterns on your self-report form. He's not paying attention at all to what he's answering. Now again, there's a lot of things we train our testers to do, let's take a break, let's walk around, let's start over again. But again, all this is important for interpreting the information you get from the test. Now again, this is limited on its own because it's limited to what can be observed. That is, you often can't get something like if an adolescent is showing a lot of anxiety or feeling a lot of anxiety but is not expressing it. It's also subject to reactivity. When you go into the classroom and watch a child, oftentimes the child will be on his or her best behavior. And it's often costly to do, there are a number of very standard observational systems that you can use. Several rating scales like the BASC and the Child Behavior Checklist actually have direct observational forms that you can use. But that requires often a lot of training to be able to do reliably. But again, my view in terms of measures is that any evidence-based assessment should have at least behavior rating scales, observations, and unstructured interviews as part of it. Now, what about other possible inclusions? One of the things that we use a lot in our clinic are structured interviews. These are interviews like the DISC or the ADOS or other structured interviews that specifically go through symptoms of a lot of childhood disorders and have very specific questions about, is the symptom present? How many symptoms are present? How long they've been going on? How impairing they are? And it's very interesting, and this is one of the things that was very helpful for me in doing this both in private practice and in our clinic. This was one of the differences between the assessment that I gave in the clinic that I ran where students were doing the evaluation and when my time was valuable in private practice. I didn't do these structured interviews a lot in private practice. And because they're very time consuming. I thought they were very helpful for students because it helped students learn about the diagnostic criteria. And after doing them for 8 to 10 years as a student and then through the clinics, I sort of became good at asking those questions in my unstructured interviews for that. But because they're time consuming, I don't think that they're often used a lot in private practice. But we find them very helpful in our clinical assessment service that's part of our psychology clinic. Often, kids' emotional and behavioral problems are intertwined with academic problems. So we'll often use intelligence and achievement tests as part of the evaluation. There's some times where we have an evaluation where we have standardized test score from the school that says the child is doing well. The issue of learning and learning problems is really not at all, and we may do a very brief screening for this. But otherwise, we'll often have intelligence and achievement tests as part of the assessment. Sometimes we'll actually go out to the school and do peer ratings of children to where we see how peers view them. And often we'll get records. And I really debated about this was one where maybe it should be an always included because at the very least, we'll always have parents bring in report cards of their child. We'll have them bring in any past testing, whether it's school standardized testing, whether it's actual NEA testing that's done by another psychologist. We'll have them bring in these records for us to review as sort of more objective information about the child's adjustment. And now, here's where I usually evoke a storm of criticism, is what did I exclude from this list? One notable exclusion is, laboratory tasks. In my research, we often do things like we will assess children's how they respond to emotional stimuli. Because I'm interested in studying callous and emotional traits. You see, I couldn't go through a whole session without saying that. So we're interested in looking at how kids respond to emotional stimuli, which we think is very important for starting to understand some of the pathways kids go through to develop conduct problems. But I will tell you, as a big advocate of those things, I don't find that they're very useful yet in clinical evaluations. I don't know yet how to use these scores. They haven't been used by enough people in large samples for me to know, how to use scores from that test. Another example is continuous performance tasks for attention, where you have a number of things that have been used with large samples for a lot of kids. The issue comes in is, let's say you have a child who is scoring poorly on a continuous performance task, but is not showing any problems according to parents, teachers, or child. They're only scoring, they're having problems on the continuous performance task. You're probably not going to do real in-depth treatment other than to tell the child, don't go near continuous performance task and you'll be fine. On the flip side, let's say you have a child who teachers say they're having a lot of problems, parents are saying they're having a lot of problems at home and at school, yet they're doing fine on the continuous performance task. You're still probably going to do an intervention to help the child's attentional problems. And so the issue is what they add relative to the training and time has not proven to be very useful in most evidence-based treatments. And I'll use the same example for projective tests. The time they take to score, to administer and score for most of them, and the information they provide has not proven to add much to other things in terms of evidence-based treatments. And so for both of these reasons, these are typically not included in an evidence-based approach to treatment. Now, I'll give you time to, we're going to have time, we'll have a lot of time to discuss this. I want to do one final thing in terms of this thinking about measures. Remember this hypothesis testing approach that I outlined earlier? You define the referral question, you decide what data should support one hypothesis over another, you design your data collection, you collect the data, and you determine what hypothesis is most consistent with the available data. Most texts that discuss assessment sort of stop there and say it's sort of up to the clinician then how to make this step 5, how to determine which hypothesis is most consistent with available data. And one of the things that I've actually gotten the most comments for in our textbook is we included a chapter that really tried to help people who are clinicians who are doing these testing, how they can process all this information. Because look at what I've just painted for you. For most diagnostic assessments, you're going to end up with a lot of different scores, a lot of different information from different sources, from different methods. You're stuck with this and you're saying, okay, what the heck do I do with all of this? How do I determine what hypothesis? I do think that hypothesis testing structure gives you a guide. But we've tried to come up with, here's a step-by-step approach that we think can help you make sense of all of that information. And you start with the most sensitive measure. You go through and make a list of what are all the clinically significant findings that I get on this child. What rating scales, subscales are elevated? What findings did I come from my behavioral observation? What historical information is significant? You document all clinically significant findings from that. You then look, okay, what areas converge? Where do I have information from more than one source on this child that converge? Now, what we love is if everything converged. If the child, the teacher says the child is hyperactive, the parent says the child is hyperactive, you go into school and you observe the child being hyperactive, you're, yes, I'm pretty confident. But you know what the research says? Across those different measures, they correlate about 0.30. Now, you guys who might not, know statistics that well, that means they share about 99% of the variance. And if that doesn't help you, what that means is more often than not, they'll disagree. They won't converge. And so that leads you typically to you have the parent saying it's there, but the parent not saying it's there, the teacher saying it's there, and so they don't agree, and the child not saying it there. So all you're getting it is from the teacher. So then you go through a process of trying to determine why these discrepancies are there. So for example, in attention deficit disorder, one of the things that research shows you is that sometimes parents don't put the same demands on the child as they do in school. I remember one assessment that had that pattern of discrepant findings, And we talked to the parent, and they said, we're here because of the teacher. I don't have any problems with them at home. It's just the teacher. She's, burnt out and just is not structured in the classroom. Say, okay, so you don't have any problems at home. He sits fine at the dinner table. Well, we don't make Johnny sit at the dinner table because it was too disruptive for everybody. Okay, so he does his chores. Well, you know what? We quit giving him chores because we'd have to go behind him every day. And okay, so what about church? Being in the South, that's a big thing. Does he do fine in church? Well, we were asked to leave the last church because Johnny was so disruptive in the nursery. So you're right. The parent's not having a lot of problems with the child, right? But what you've done is you've come up with an explanation for why that divergent information might be there. Your hypothesis is if the parents put the same demands or age-appropriate demands on the child, he would be having problems. Then what you do is based on that, you develop a hierarchy, based on your what problems converge, what problems are discrepant, to saying, okay, here's what we think is primary, here's what we think is secondary, and this is one of the more difficult things. Looking at, what problem came first, what problem is causing the most impairment for the child, and then deciding what should go into the report. Now, again, in the interest of time, I'm not going to be able to go into a lot in terms of report writing, but I do want to tell you one thing that I think this approach to testing really highlights. It's how you organize a report. I don't know how many of you guys have read a psychological evaluation where it will go test by test. Here is the WISC, and here's my cookbook interpretation of the WISC, the intelligence test. Here is the child's achievement, and here's my cookbook interpretation of the achievement test. Here is the BASC rating scale, and here are all the scales that are elevated or not on the BASC. Here is the behavioral observation, and here is all the significant findings. And it goes by test, and that's very hard to read. You're getting all of these, some positive findings, some negative findings, some that don't converge. And a person reading this says, I don't know what to make of all of this. What I have what we do in our reports in our clinic is you're doing that whole process of coming up with what are the primary and secondary areas, and that's how you organize your report. So let's say you come up with the fact that this child was depressed and his conduct problems really came on after his first depressive episode, and he really only shows conduct problems, when he's depressed. So the way you organize your report is the primary reason for this child's conduct problem seems to be a substantial level of depression. Here is the evidence to support that. On a self-report rating scale, the child scored above the 99th percentile. In a classroom observation, we saw that the child was withdrawn and sad looking. The parents report that the child has lost appetite, he can't sleep. What you've just done there is rather than going through each of the assessment measures, you're sticking to here's what's important, here's all my evidence to support it. Then the next section of your report, the second area of concern is behavior problems. This is evidenced by the teacher's report on the Achenbach aggressive behavior rating scale, using it the way it should be done, where he shows conduct problems over the 90th percentile. However, according to parental report, this only occurs during depression. So, for example, parent reported that it was not a problem in prior to 6th grade when he first had the first depressive episode. This is supported by report cards that was provided where his grades and conducts were satisfactory until the 5th grade. You see what you've just done? You have organized it around your case conceptualization. This is how we do our reports that really fit. And you see how this fits with an evidence-based approach? It tells you what is the data that supports my interpretation that anybody can see in a organized way. The following thing is your recommendations should follow from that. If your conceptualization said the primary problem is depression, then your recommendations should start with what is an evidence-based treatment for depression. If the primary problem is attention deficit disorder, it should start there. I can't tell you how many reports I've read where they say the primary problem is depression, and then they go through making recommendations for peer problems and conduct problems, not really targeting what seems to be what they said was the main problem. And so that all follows from organizing it around this case conceptualization. The other thing, and this comes from more evidence-based approaches to doing this in person, make sure you include strengths about the child in your report. It's funny, after doing this before I had kids, it really didn't seem as important as after I had kids. I had been doing this for a long time, and thinking that, with my child, I won't be defensive, because I've been doing this. I know what it's like to have your child. And I remember my first child, he was being born. Now, in my defense, it was 5 a.m. when he was being born, so I had been up all night without sleep. Now, of course, my wife has no sympathy whatsoever. She was in labor all night. But, comes out and he gets his APGAR score. And I got to lead up to this. We were in there, and I had read all the research about forceps. Well, they had the vacuum that turns a child's head. Well, the nurse dropped it, and it broke, and so they had to use forceps. So I was already stressful there. Well, the child, Josh comes out, and the nurse gives him an APGAR score of 6. So I go over to the nurse and say, why is it a 6? She said, well, he scored low here. I said, no, if you look at this, it shouldn't have been scored a 6. And so the nurse and I got into a huge argument about his APGAR score. Now, my wife tells me, I don't remember this part, that at one point I was yelling at her saying, he's not a 6, you're a 6, he's a 10. But to me, right out of the chute there, I was defensive about any score that's given to my child. You have to know that when you're doing an evaluation. You have to set the right context of, talk about the child's strengths as well as the child's weaknesses. Reduce that defensiveness there. All right. Now, I know, we're getting to the point where we want to have a lot of discussion. So what I want to do is, I do want to talk about applying this. And it was one thing is, in an hour, I couldn't say, this is how you apply it to depression. This is how you apply it to anxiety. But I did want to kind of give you an example of applying this to a specific disorder, and then to give you a case presentation. And that's where I wanted to promote discussion from you guys. I wanted to take a case and show you how we apply this and allow you to ask questions about applying this. So the first thing I'm going to do is, let's say you've done your hypothesis testing, and you think this child might have attention deficit disorder, and that's one of your hypotheses. So the way to apply this is then you look at the research. What types of things does research show you should look for in terms of assessing a child with that might have attention deficit disorder? The first thing is the core features of attention deficit disorder are inattention, disorganization, impulsivity, of hyperactivity. So what that tells you is, in your assessment, you need to have a reliable assessment of these core features that are part of the DSM. This inattention and disorganization, this hyperactivity and impulsivity. Reason this is so important is, if you look at a lot of attention problem scales that are out there, they don't really cover these core symptoms well. It also has to be done appropriate to the child's developmental level. The second research finding is, if you look at these things, how many people here have not shown at least a few of these symptoms within the past week? Nobody? Now think about a 6-year-old or a 7-year-old. Some level of this is developmentally normative. So what research says is you need to differentiate normative from pathological manifestations of these symptoms. That's based on the severity. Do they show, 6 or more in any one of those domains, which has been associated with impairment? Is it more than what you'd expect for a child's age? The severity of the core features. How long have they been going on? If you have an adolescent who's referred to you in late high school and showed no signs of this early on, that makes you suspect that's not consistent with attention deficit disorder. It may have gotten worse once the child gets to junior high or high school, but these symptoms are often present early on. We often know that these things are present across situations. Now again, remember the example I gave you a little while ago about it's seeming to not be present at home, but just at school. You do have to take into account, is this because there are not demands placed at home? But it does need to be, you have to ensure that it's not just a function of one environment of the child. And to be honest with you, one of the most important things is, how impairing is this for the child? Can I document that these symptoms are causing the child significant levels of impairment? All of these things come from research. The other thing is, what does research say are other things that could cause attention problems and impulsivity and hyperactivity? And can I rule out that that's not the cause that's going on here? So you have intellectual and learning deficits that can look like attention deficit disorder. You can have, inconsistent and unstable home environments. Sometimes kids who are very anxious in certain situations can look very inattentive. Substance use can look like, make a child inattentive and look impulsive. And certain medications can make a child look. Sometimes certain very second-line asthma medications actually can lead a child to be very restless, irritable, and impulsive. So you want to make sure you know what kind of medications the child is on. And then you need to assess a host of comorbid problems. Things like conduct problems and aggression. We know from research that somewhere between 40 and 60% of kids that have attention deficit disorder also have significant conduct problems. We know that about 30% have significant learning problems in addition to the learning problems caused by the attention. It's not just that they're making careless mistakes or not finishing their work, but they also have learning problems specific to, say, reading or math. Many kids with attention deficit disorder have anxiety, depression, or at least low self-esteem. They have problems in social adjustment. They have problems, interacting with kids, and they cause a lot of conflict both at home and at school. So what I've just given you here is you would do the same thing is, let's say, anxiety is the primary cause. You would look at the research and do the exact same thing. What are the implications for how I design an assessment? Just like I did there for attention deficit disorder. All right. Now, I've been doing a lot of talking, and this is a point of discussion where you can ask me questions. But let's start with a kind of structured discussion. What I want to do is give a case study and then get you guys involved in terms of how to use this type of evidence-based approach. And what I did was I went through the kids that we just assessed, last semester in our assessment service. I pulled one that was sort of, not totally, difficult, but also not run-of-the-mill. And this was an 8-year-old boy who was referred because of school problems of academic performance. Described as being very smart, and this was his parents' exact words, and that he could do his work in one-on-one situations. The parent said when she's at home, working with him one-on-one at home, has no trouble doing his homework, yet he's failing all his classes. He does poorly at school, and his parents say primarily because he can't stay in his seat and focus on his work. He's also described as, I quote, being inconsiderate of others. He just annoys everybody, and he's had multiple detentions at school. Okay, that was our referral question. So, what hypotheses would you start with? What do you think could be going on for this child? This is where you guys can jump in.
They have a learning problem.
All right, the child could have a learning problem. And when you say learning problem,
Reading disorder.
so like a reading disability, okay? Or a specific learning disability. What else?
Depression.
Depression. Why depression?
Because they're supposed to be very smart for doing poor academic, could be.
Okay. What else?
Aggressive.
Aggressive. Maybe a child has conduct problems.
He has ADHD.
Maybe he has ADHD. Yeah, you thought that was a little too obvious, huh? There. All right. So here's the next step. All right. I don't want to pick on you guys, but you guys who respond, Like, what would make you think what data would make you think it's a learning disability?
He's very smart, yet he's failing some of his classes.
Okay, but what would what would you look for to see if that's the case? What more information would you gather to see if that's the case?
Is he failing a specific subject?
Is it confined to a specific subject, or is it kind of across the board, him failing? What else?
Does he only start annoying kids in the subjects that he's doing poorly in?
To where there's one subject, if a child has trouble reading, they're going to pretty much not try in reading and start doing other things, and maybe that's where the behavior problems are.
Is he so smart that he's getting bored and creating trouble?
Okay, is he so smart, is he getting bored?
This child could also have Asperger's syndrome.
All right, we'll come to that too. So that's another hypothesis. But with the learning, what is his scores on standardized tests? Is he really as smart as the mother thinks? I happen to have 3 genius kids, and so, I don't have to, be in denial. But some parents are in denial about how smart their children are, and so maybe she's inflating how smart he is. All right, depression? What would you look for there? Anybody?
Memory problems.
Does he have memory problems? What are his scores on depression inventories? Can we document that that they've gone through periods of being depressed during episodes and then is fine at other times, and his behavior problems and learning problems really coincide with those episodes of depression? Attention deficit disorder. What would you look for?
Want to know what the family's doing to help him be structured at home when he's able to pay attention, and the level of his fidgetiness and staying on his feet at school.
And you'd go through, what I just outlined, assessing the core symptoms, assessing whether they're non-normative, ruling out, alternative causes. Asperger's. What would you want to collect for that?
You need to decide how he interacts with his peers.
Okay.
Does he have any social communication problems? How does he interact at home and does he have friends? Does he get invited to places? What is he like in all contexts?
And how would you do that?
You'd have to talk to his parents and find out if he gets invited to birthday parties. Does he have friends at home? What has his developmental milestone been like all along? When did he attain language? What has his prosody been like? What has his language been like all along? What have his developmental milestones been like with language? What was he like as an infant? What have his milestones been like all of his life? And then you have to do some testing with his intelligence. Sometimes these kids have hyperlexia in reading, and sometimes they don't get jokes. They're very funny in jokes. They don't understand jokes. They don't get the punchline. They have problems with, in the early time between 18 and 24 months, they have difficulty with language acquisition, but it's a different language. They usually have normal acquisition of language in that they attain language, but their acquisition is different in that they don't really understand language in the same way as most children.
Right.
But,
all right, and this is important. All right, so, you're asking this question here is, okay, so would I really need to, with this child, design that comprehensive evaluation? Because you're absolutely right. To make a diagnosis of Asperger's, you would have to do something, and you would add, you'd probably do some observations at school. You would add a lot to this. So one of the things for example, what we would do in this case, and what we did in this case, is we started sort of in a multiple gating. We didn't do all of the things you said. We did get a developmental history. We did get developmental milestones. But we did an initial evaluation of his peers, what types of peer problems he's having. We looked at his score on some of the scales that we were given. We gave the child behavior checklist. We looked at that. We talked to the mother about what types of problems he was having. And so it did not seem like he was lacking social skills, and even in his interactions with us and when we observed him in school. So we ruled out that through a screening, and if that screening had been more suggestive, we would have done the more in-depth evaluation that you're talking about. And you see, this is what I'm trying to paint for you is, you see how this is guided by hypotheses. We entertained, and I'll say it, even forget about Asperger's, what we entertained was, is his primary problem due to lack of social skills, maybe due to Asperger's or some other reason for social skills, and through our initial part of the evaluation, did not feel like we needed to do more assessment there. And that's how we were following this, designing the data collection, often in multiple stages. And so we went through what we just talked about in terms of these evaluation of attention deficit disorder. And let me just give you, I'm going to go through this very quickly, because I want to give you a chance to ask more questions. All right. Now, this is what I want to highlight here. We went through, and we did everything you're talking about. We gave an IQ and achievement test. We got a lot of background information, developmental history, a lot of information on the child's behavior in school. We looked at where he was having problems. We gave a structured interview. We had rating scales, and we went out to school and did an observation. And so let's go through this process of pulling this all together. In the unstructured interview, the parent said this child had been hyperactive and had difficulty following instructions since the age of 2. And this child had actually been expelled from 2 preschools. That's what the parent actually said. I didn't realize you could actually be expelled from preschool. But he was asked to leave 2 preschools. The parents had separated 2 years earlier when he was 6. And the parent did say, he really has no friends. He said he just annoys everybody who tries to be his friend, and they just can't be around him for long. In the structured interview, he met criteria for ADHD and ODD. When you looked at rating scales, for the parent, 99th percentile for ADHD. He also was above norms for conduct problems, depression, and somatic complaints. Teacher, 97th percentile. Conduct problems, social problems, this was on the child behavior checklist. When we went to the school, he was rarely in a seat. The teacher had actually moved him to the front of the class, but that didn't help because he was never in his seat during the whole, we observed him for a whole morning. The other children largely ignored him, especially when he was going around trying to bug them during the class period. Never followed class rules. They had this stoplight thing where his stoplight was always on red, which meant he had violated class rules. And we saw him, school started at 8, and by 8:45 he was at red in terms of the stoplight, in terms of behavior problems. Interestingly, with the IQ, his overall IQ score was like 96. And both the perceptual, organizational, and verbal were all right in the low 90s, but his perceptual speed was 71. Working memory was fine too. So it really was just one subtest, and his achievement test scores were actually all right around 100, right average for his age. All right. So what is consistent with all of this? ADHD. We got that from the observations. We got that from the teacher. We got that from the parent. We also had pretty consistent information about conduct problems. We also got pretty consistent information about social problems. Now again, our view was it was not that the child was missing social cues per se. He was just very impulsive and annoying in his social problems. But what was discrepant? Depression and somatic complaints from the mother only. How would you explain that?
Is mom depressed?
Is his mom depressed? Yes, actually. Very good. One of the things that we found from the mother is that since the separation, remember 2 years ago, and impending divorce, that she had been under the care of a psychiatrist and on antidepressant medication. That didn't seem to be working real well at the time we were doing the evaluation. So but why is that important?
Well, she's pretty much putting her own symptoms in the child, perhaps? Her own symptomatology?
But how would you guys distinguish between, parents who are depressed also are more likely to have kids who are depressed. So how would you know what would make you think how to interpret this as whether the child's depressed or not? What's that?
The behavioral observations.
The behavioral observations. And again, we saw no indicate the child did not look depressed to us or look depressed, and the teacher didn't say he was depressed. And we got no other indication except from the mother. What else would you do to make sense of that? Yes?
Is it possible he's just sad and kind of having some sick feelings before going to school in the morning, and the mom is seeing that, but nobody else is really seeing that since he's at home with her?
And this is something we got from the structured interview, is when you asked the mother about his depression, it was really, he's so frustrated. He really wants to do better in school, but he's so frustrated. And, when you talk to her, about the depression, it didn't seem depressed. It seemed like he was just frustrated. Because when we asked him, what makes you think he's depressed? Well, he just, you can just tell. He doesn't have any friends and he's frustrated. And we never could get very specific information about what was the depression, even though it came out high on the child behavior checklist, anxiety and depression scale. What about somatic complaints?
Well, I was just going to say, if the mom is depressed and she's not able to do the parenting that she wants to do, then he may want to stay home to take care of mom, and he's frustrated because she's not parenting him in the way that he needs to be parented.
She is, and she was definitely frustrated. She basically said when she came in here, I don't know what else to do for him. And in fact, one of her words were, I don't have it in me to take care of him anymore, was one of the things she said in her unstructured interview. All right, school grades. We got, he was getting Fs, yet his achievement scores were grade appropriate. That was discrepant. What would you make of that?
The learning environment.
In what way?
Well, he's not comfortable at school. He's not learning. He's learning.
He's learning.
Achievement is proving otherwise, but I don't think he's comfortable at school, therefore he's failing at school.
And what we got from this was that he, a lot of his failure was not turning in assignments, making careless mistakes. We had the teacher give us some of the tests that he got an F on. And he was 8 years old, and he did his whole section of long division as multiplication. And they were actually right if it was multiplication, and he got them all right, but they were all division problems. And so we got the teacher to give us several things. And so it seemed to us that most of his grades were due to the attention problems. So here's how we did the case conceptualization. We did feel like the attention problems were primary. Because one of the things we found was that the child was really more hyperactive and inattentive in early grades, and the social problems and behavior problems really seemed to come about in later grades, and because he was very impulsive. He did seem, like in one-on-one situations with us, he did seem to have social skills. He did seem to be able to relate to us and pick up social cues, but he just would act very impulsively in the classroom. And so what we did here was our recommendations for treatment really focused on a combination of stimulant medication and behavioral management for his attention deficit disorder, since that's what we felt like were his primary problems. We felt like his depression, if it was there, was probably due to his frustration over school. So we made that as our primary problem. And we felt like that focusing on the attention problems would also solve the behavior problems. But I want to also pull up, just so you can get more information about this. I've given you a few key references, and I know they're somewhat self-serving key references here. You'll see Frick in at least 2 of the 3. This is, as I mentioned, a chapter that will be coming out from an APA handbook that really summarizes, that gives you the 3 principles that I talked about. and does a little bit more in-depth talking about specific problems. In our textbook, we really take, rather than just saying behavior rating scales, we actually do each go through a number of rating scales and say what we feel like their strengths and weaknesses are in terms of what they assess. As I mentioned, Mash and Hunsley, besides their special issue, have a edited textbook. And I'll also bring you, in the special issue that was done in 2005, in both our book and in the Mash textbook, they go through ADHD like I did, but in addition, they go through autism, depression, anxiety, conduct problems, and they go through what does the research say about this, just like I did for ADHD, and how that should determine how you tailor the evaluation. And also in this special issue, they had articles related to the different types of problems. So that's the reference list that you have for, I know, getting more specific information.